Hi, my name is Meg Begany, and I am a neonatal dietitian at the Children's Hospital of Philadelphia. Today's course is just one in a series of subjects brought to you by Channel 1, On-Demand Nutrition Education. Today, we are looking at infant bone health, screening and prevention of metabolic bone disease, Part 2. Our objectives for Part 2 are to identify screening methods for infants at risk for metabolic bone disease, and to show an example of a clinical pathway for screening infants at risk for fractures. There are no universally accepted screening or diagnostic criteria for metabolic bone disease. However, some radiographical and biochemical markers can aid in the detection and diagnosis of metabolic bone disease. Plain film radiographs, or X-rays, are the most commonly used and widely available radiologic modality, but have several limitations. Interpretation is subjective depending on the reviewer, and factors such as exposure can affect the interpretation. Early stages of metabolic bone disease are difficult or impossible to detect, as significant loss of bone mineralization is needed before being visible on an X-ray. Acute fractures may not be detectable until 2 to 3 weeks after they have occurred, when a callus formation begins. DEXA is another radiological tool that has been explored for the detection of metabolic bone disease. However, it is not often utilized in clinical practice for infants due to limits of age in the data set, distortion of results due to movement of the infant, and practical limitations such as cost and availability. Quantitative ultrasound shows promise as a screening tool. Studies by Altunco et al. And Rack et al. Have demonstrated an inverse correlation with elevated alkaline phosphatase and low tibial Z-scores. However, quantitative ultrasound is not currently readily available and often limited to a research tool. The most common biochemical screening tools for metabolic bone disease include serum calcium, serum phosphorus, and serum alkaline phosphatase. These are often considered the primary screening labs for metabolic bone disease and are readily available tests in most centers. Unfortunately, serum calcium as a screening tool has some major limitations. Hypocalcemia may be a late finding and is limited, as most infants, even with poor intake, are able to maintain normal serum calcium levels at the expense of bone. Rustico et al. Noted that a calcium level less than 8.5 is suggestive of inadequate calcium intake. Serum phosphorus is the earliest marker of disturbances in mineral metabolism, with hypophosphatemia occurring by 7 to 14 days after birth in infants with inadequate intakes. Baxter and colleagues demonstrated that a serum phosphorus concentration less than 5.5 milligrams per deciliter is associated with radiological evidence of rickets. Alkaline phosphatase is a known marker of bone turnover and may be helpful for trending. An alkaline phosphatase over 500 has been associated with metabolic bone disease, particularly in extremely low birth weight infants less than 30 weeks gestational age. In a study of infants who were less than 33 weeks gestational age, an alkaline phosphatase of greater than 900, along with a phosphorus that is persistently less than 5.6, had a diagnostic sensitivity of 100% and a diagnostic specificity of 70%. So this combination of an elevated alkaline phosphatase and a low phosphorus may be particularly helpful in identifying infants at risk for fractures. Of note, alkaline phosphatase may be elevated due to factors other than metabolic bone disease, such as liver dysfunction, and therefore should be used in conjunction with other clinical factors when deciding if an infant has metabolic bone disease. Obtaining a fractionated alkaline phosphatase may be helpful in some situations. Additional laboratory tests that can be used for screening for metabolic bone disease include vitamin D and parathyroid hormone. A concentration of greater than 50 nanomoles per liter of serum 25-hydroxy-vitamin D is desirable. In publications by Rustico, Calabria, and Garber, and by Moriera and colleagues, a PTH greater than 100 was defined as suggestive as risk for metabolic bone disease. Renal tubular reabsorption of phosphate, or TRP, is another value which may help guide management of metabolic bone disease. TRP is calculated using the equation at the bottom of the slide. TRP measures the fraction of phosphorus that is reabsorbed by the kidney. This value is often used in conjunction with PTH, where a low TRP with an elevated PTH may suggest deficiency of calcium in the diet, while a high TRP with a low or normal PTH may indicate a diet deficient in phosphate. Depending on the serum phosphorus concentration, a small amount of phosphorus in the urine is expected, and values of 85 to 95% renal reabsorption are considered normal. Involving an endocrinologist or a dietitian with specialized knowledge in metabolic bone disease can help in interpreting the laboratory values discussed and implementing subsequent treatment strategies. The American Academy of Pediatrics Committee on Nutrition recommends screening with serum phosphate and alkaline phosphatase starting at 4 to 5 weeks of chronological age. Routine monitoring of serum phosphorus level should be started 2 weeks after birth for early detection of metabolic bone disease, particularly in the extremely low birth weight infant. Monitoring of biochemical markers should continue at least every 2 to 4 weeks thereafter, depending on risk factors and results. Some studies have suggested that the use of a clinical protocol or pathway for screening infants at risk for metabolic bone disease allows earlier supplementation and subsequent resolution of abnormal levels. One such study by Sabrowski et al. Showed that with a protocol in place, there was a 62% reduction in the number of infants with an alkaline phosphatase level greater than 800 IUs per liter, as well as a reduction in the percentage of infants who had concurrently low phosphorus and high alkaline phosphatase levels. At the Children's Hospital of Philadelphia, we have implemented the use of a screening pathway for infants at risk for metabolic bone disease or fractures. This pathway can be publicly accessed via the CHOP Pathways Library at www.chop.edu. Our pathway utilizes both primary and secondary screening tools to identify infants who may benefit from an evaluation and treatment led by an endocrinologist with expertise in neonatal bone health. If you work with at-risk infants, I encourage you to utilize this or other resources for screening and prevention of metabolic bone disease. In summary, metabolic bone disease is a prevalent and often under-recognized disease in hospitalized infants. Early screening, diagnosis, and treatment is recommended to prevent short and long-term clinical sequelae. Use of pathways and protocols may aid in the prevention and detection of metabolic bone disease and fractures. I would encourage you to watch for upcoming Channel 1 videos on nutrition and learn more from my esteemed colleagues. Have a great day.